Next, I'm going to invite Dr. Mamatha Bhat. She's a hepatologist, assistant professor of medicine at the University of Toronto, and leads the Transplant AI initiative at the University Health Network's Ajmera Transplant Center. Dr. Bhat completed her medical school and residency training at McGill, and then completed a transplant hepatology fellowship at Mayo Clinic in Rochester, Minnesota. She subsequently completed a PhD in medical biophysics through a CIHR fellowship for health professionals. The goal of Dr. Bhat's research program is to improve long-term outcomes in liver transplant recipients and liver transplantation improve the outcome through a precision medicine approach. Her program is unique in using tools of AI with bioinformatics to personalize the care of liver transplant recipients based on an improved biological understanding of the liver and disease after transplant. Her interdisciplinary research program has been supported by the Canadian Institute for Health Research, the Canadian Liver Foundation, and many other programs. Dr. Bhat is a partnership and engagement lead for TCARM and has been recognized for many different awards and has been the recipient of the 2021 American Society of Transplantation Basic Science Career Development Award. Please join me in welcoming her to the stage.
Hey, thanks so much, Kai, for that kind introduction. And it's really my pleasure to be with you all of here at the MLHC. So I'd like to thank the organizers for the kind invitation to present to all of you. So I'll really be speaking about my experience leading an interdisciplinary team. So I have a highly interdisciplinary team wherein half is comprised of computer scientists working very closely in association with clinical fellows and residents, so computer science postdocs and graduate students, as well as clinical fellows, bioinformatics. So we have a range of disciplines represented, and I think that we managed to grow knowledge together by having constant crosstalk and learning from each other. So I would say that I've learned a lot, from graduate students and postdocs in my group, and what happens is vice versa. They learn from the clinical knowledge that I have, as well as my advanced clinical fellows have, and it's by those constant conversations that we end up getting interesting new ideas to improve the care of patients. So ultimately, that's really what inspires me in my own work. And I was telling people earlier, certain conversations I've had with patients can trigger an idea, or, say when I'm attending on the liver transplant service, which I am this week, there may be an interesting situation or condition that a patient has, or a presentation that a patient has that then, inspires a certain research idea. So in the end, it's really those clinical questions that then inspire the work we do in my research program. So I also co-lead our Transplant AI initiative, which is basically an effort that is supported by our transplant center to both develop as well as deploy tools of AI across our transplant center. So these are my disclosures. And so first of all, so in this talk, I'll go over why machine learning tools in liver transplantation and why I was particularly interested in exploring the potential for application in my world, in my clinical world. And then I'll go into specific instances in patients both pre as well as post-transplant. So where I saw areas of need, where I thought that AI tools might actually have a benefit and would be very interesting to explore. So, what really inspired this was I was towards the end of my PhD in bioinformatics, so in medical biophysics at University of Toronto. And I started hearing about some interesting studies that were coming out in JAMA on diabetic retinopathy and on skin cancer recognition, and it was all imaging based. And I thought, as a hepatologist, I'm looking at a lot of patterns in data and trying to, for the individual patient in front of me, understand what this means for that specific patient in terms of their prognosis, in terms of my own therapeutic recommendations for that patient. So as a hepatologist, I often look at the ALT to AST ratio, or vice versa, the alkaline phosphatase, and then I look at trajectories over time to then understand, well, what does the history tell me about their future? So I was often doing this, and I thought, well, it might be very interesting to explore the potential for this. So although my training itself was not in computer science, I do have a coding background. I started reaching out to different people across the University of Toronto ecosystem as I was completing my PhD. So I reached out to people like Anna Goldenberg and then Bo Wang about a year or two after that. So I started reaching out, seeing based on their own expertise whether they might be interested in collaborating. And so those collaborations ended up in very nice papers that were actually, so I'll talk about them. But basically the idea was that I saw all these patterns in tests that I was trying to understand and subconsciously trying to make these personalized predictions. Now, apparently the human brain can not really account for more than 4 variables at a time, notwithstanding longitudinal trajectories. So this is particularly why I think it's interesting to consider AI tools as co-pilots in the care of patients so that we can optimize and personalize the care of a patient. And there's such complexity and diversity of data that we collect on a day-to-day basis. And so we have summarized the literature. My team and we have summarized the literature around, say, machine learning in liver transplantation and solid organ transplantation in some review papers that are cited here. Additionally, more recently, last year, we had published a review in Journal of Hepatology on applications in different spheres of liver transplantation. So those include waitlist prioritization, as well as donor-recipient matching, and post-transplant outcome prediction. And these are all highly complex decisions that are fraught with some subjectivity or potential for subjectivity. So this was another interesting sort of area of need that I saw in my experience as a hepatologist, interacting with other transplant physicians and trainees. I saw that there was some subjectivity in the decision making. Of course, we are as a team trying to make the best possible decision for the individual patient as a committee in these different areas. But there is some potential for subjectivity. So how can we make these life and death decisions, because particularly deciding on the candidacy of a patient is a critical life and death decision. So how can we make such decisions the most objective possible so that you have the most equitable decisions that are made that will result in good outcomes. So that really, also inspired me in this work. And again, this is a review that we published last year that kind of summarizes the applications of machine learning in liver transplantation. The other thing, as I mentioned, is dynamics. So there's a lot of dynamics in the way patients behave. So for example, on the liver transplant waitlist, a patient may be listed with a certain severity score. So they may be at a certain level of illness when they're put on the liver transplant waitlist. But the reality is that their situation is dynamic. So they may be stable for 3-4 months, but then suddenly an infection pushes them. So it stresses their liver, it stresses their kidneys. So then unfortunately, they can go downhill very quickly. When the liver is stressed, the rest of the body also gets stressed very often, particularly in more ill patients. And so what then will happen is if the patient recovers from that infection, they settle at a higher level of illness severity. And so the reality that I saw, and I'll discuss that in the first project that I present, is, I had an intuition that actually, it wasn't their blood test results on that given day that predicted their risk of death or dropping off the wait list in the next 3 months, but rather the history in addition to the current blood tests. So we'll get into that in the next project. But I think it's important to consider that a patient's illness or a clinical condition is not static. There's a lot of dynamics. And then there are things that can change based on the intervention, and based on physician behavior, based on local circumstances. So I think that's the reality of medicine in general, but in liver transplant medicine, this is something we see very often, and I thought it would be very interesting to model these dynamics. And so in our work, we have used a lot of sort of time series models in order to best kind of reflect that dynamic change in severity of illness and risk of dying or risk of dropout off the wait list. Okay, so we'll start with the first project, which is predicting dynamic trajectories on the wait list using machine learning. So there are significant inequities in liver transplant prioritization and allocation. And again, this was a project actually inspired by my own personal experience. So as a hepatologist, particularly in my earlier years as a hepatologist, as I said, I was recognizing that there were patterns in data, so that was one thing that could be subconsciously generated for personalized predictions, but it's subconsciously integrated for personalized predictions. But in addition, there were some inequities that I was recognizing in people being able to attract or receive donor offers. So this is how it works. So on the liver transplant waiting list, patients are ranked in terms of their severity of illness, and that is based on the MELD sodium score. The MELD sodium score is basically an integration of the INR, which is the International Normalized Ratio. It's a function of clotting time, bilirubin, creatinine, and sodium. So those are the 4 parameters that we consider in prioritizing patients on the liver transplant wait list. So the reality is that some people's illness is not very well reflected by that particular set of 4 blood tests. So the reality is that such patients unfortunately are disadvantaged because the supply of organs is unable to meet the demand. And so 25 to 30% of the patients on our liver transplant wait list, those whom we have determined are candidates for transplant and we place on the liver transplant waiting list, are unfortunately going to pass away due to severity of illness, or they drop out, meaning that they become too sick for a transplant. So if they become bedridden, then they're not going to be able to enjoy success with transplant, and so they are no longer transplant candidates. So I was recognizing these inequities, and so I'll talk about a few principal inequities that I recognize. So one was that women appear to be less likely or less able to attract organ offers. So, I noticed that, and I noticed that there were some, younger women, smaller body habitus who were not, making it to transplant. And so that, fundamentally bothered me. So I then looked into the literature. In fact, I was invited to give a talk at the Canadian Liver Meeting on disparities in liver transplant. And actually, that's what kind of triggered then finally the decision to move with a project in this area. So women are 15% less likely to attract organ offers in the US experience. And in fact, in our Toronto program, they are more dependent on having access to living donor liver transplantation as a means to get to transplant because they are unable to attract organ offers as effectively. Okay, so that was one important issue that I recognized. Another important issue was that primary biliary cholangitis and primary sclerosing cholangitis, so these are 2 autoimmune liver diseases where the bilirubin is the most important blood test that predicts the severity of their illness and their mortality. So Unfortunately, in the MELD sodium score, which was developed at a time when the hepatitis C patient population was the greatest proportion of the waitlisted liver transplant population. So that model was trained on a hepatitis C heavy population where bilirubin actually does not reflect severity of illness. So it's more the INR, creatinine, and sodium. So these patients are unfortunately disadvantaged because in that model, the bilirubin is underweighted in comparison to by a factor of 3. Okay, so this means that these patients unfortunately have to become very, very ill in order to attract an organ offer, and much more so. And then so they have a much higher risk of passing away. So in some programs, particularly ours, they are much more dependent, again, on living donor liver transplantation. And then as I mentioned, there's been a shift in the underlying patient cohort. So hepatitis C now is curable, which is a dramatic development, and actually it changed, our liver transplant patient population. And now it's more metabolic-associated steatohepatitis, which is also known as fatty liver disease, and alcoholic liver disease, as well as autoimmune liver diseases. So those are the major, say, indications for liver transplantation, along with liver cancer, which comprises 35% of our patient population. So I was recognizing these inequities, and I thought it would be very interesting, again, to develop an AI model that could better reflect all those different considerations and dynamics. And so we come to this project led by Michael Cooper, who's sitting right here, a PhD student, who is supervised by Rahul Krishnan and co-supervised by me in this project. And so this is a CIHR-funded project now. And so he trained an algorithm, a deep machine learning algorithm, so a deep serve algorithm, which is a deep learning version of Cox proportional hazards model, on over 53,000 patients listed for liver transplantation in the US since 2016. So we chose to remove like the hepatitis C era from consideration, and this was decompensated cirrhosis without exception points, and we considered 13 static and time-varying covariates per patient. Now what Michael did was actually he modified this algorithm to include velocity and acceleration of each of those blood tests. So this sort of idea came because he had developed a greater clinical understanding of the question. So I think that's what I would convey to you. It's very, very important to understand the clinical background, the clinical considerations. So he only understood that because we were talking on a regular basis. There were members of my team who were talking to him on a regular basis, and he even came to observe me during a few clinics. So he understood the clinical background very thoroughly, and that's actually what led to this idea of incorporating velocity and acceleration of those blood test results over time. And in fact, that resulted in a much better performing algorithm. So we call this actually DynaMELD, okay? So dynamic model for end-stage liver disease. And so this algorithm actually performs much better in terms of rank ordering patients by risk score and by risk of death on the liver transplant waitlist. And so it does a much better job of this as compared to the two sort of standards of care. MELD sodium is still being used in Canada, MELD 3.0 in the US. And then if you actually look at the specific patient populations who are disadvantaged, as I mentioned earlier, so women are particularly well served by this model. PBC, so primary biliary cholangitis, so they do much better, would be much better prioritized with this model, as well as small statured patients. So that's another, say, patient population I should have mentioned, but like say shorter women or shorter men are disadvantaged in terms of their ability to attract organ offers. And so an additional patient population is acute on chronic liver failure, which is the patient population where you have dramatic changes or rapid changes in blood test results in a short period of time. And a clinician's intuition tells you that those patients are actually much sicker than their MELD score at that given time. So what we do with this particular model is we take into account those historical changes up until that given point in order to better prioritize patients. And so using a fairness measure called the Pooled Group Concordance Index, we determined that these patient populations were much better served. And so how that works is basically you're seeing whether members of a protected group, such as those who are disadvantaged by the MELD sodium system, are better favored in comparison to the standard group using this particular model. And as I show here, this is very clearly the case. And then we looked at what were the ranked features or the top predictors of risk on the liver transplant waitlist. And reassuringly, the top predictors were actually components of the MELD sodium score. So you can see that at the top here. But we also understand lower down that patients who have changes like velocity, increased velocity of change in different blood test results actually comprise a significant proportion of those patients who are better advantaged by the Dynameld as compared to the standard. So you can see that here. And then we can generate relative risk trajectories with Dynameld in these different patient populations, and we can also perform individualized interpretations as to the weights of these different blood tests and parameters on the risk of passing away or dropping off the liver transplant waitlist. So I think this is the beauty of, say, incorporating all these different blood tests as well as clinical variables that do have meaning in terms of understanding severity of illness. But then beyond that, we want to achieve greater equity in prioritization of patients as well as subsequent organ allocation. So now I'll move on to the second part of my talk, which is looking at post-transplant survival. And so liver transplant recipients, if you look at 1 year survival over the last 30 years, that has dramatically improved from 65% 1 year survival to 95% 1 year survival. But if you actually look at survival beyond that first year post-transplant, that has not significantly improved in the last 30 years. And it is complicated by cardiovascular disease, so heart disease, cancer, infection, and graft failure. The reality is that many of these patients, many of our patients come into transplant with a certain disease burden, and then beyond that, they're exposed to anti-rejection medication or immunosuppressive medication, which increases the risk of infection, cancer. So cancer, the immune system is actually critical for recognizing any abnormal cells. So when you inhibit the immune system, there's a much higher risk of cancer. Okay? And then additionally, cardiovascular or cardiometabolic disease. So there's a much higher risk of diabetes in our patients. So what can we do? And really the inspiration for this was my outpatient transplant clinic practice where I follow 350 liver transplant recipients. And so I actually follow them over time. And clearly, there was a lot of work that we needed to do to improve long-term outcomes. A lot of the research has been focused on short-term outcomes, surgical outcomes, but really now as we move forward, we need to much better focus on long-term outcomes because the median life expectancy of a transplant recipient, particularly liver transplant recipient, is 20 years less than the average Canadian life expectancy. So I felt like we needed to do much more, much better to enhance both quality and quantity of life post-transplant and turn transplant into a cure. And so this was a project that we published a few years ago in Lancet Digital Health. And so this was co-senior authored with Bo Wang, who's organizer of the symposium, along with Rahul. And so this work was led by Oswald Mitski, who was an undergraduate student at the time, and Amir Ajia, who's a clinical research fellow. So they both worked very closely together to drive this project forward. And so we looked at making a more personalized risk calculator for managing long-term transplant care that could be used at each follow-up, evaluating different ML algorithms. So we looked at different deep ML algorithms to incorporate longitudinal data over time. So We looked at over 40,000 liver transplant recipients followed in the US after transplant, so over years post-transplant, and we have access to that data through the Scientific Registry of Transplant Recipients. And so we were able to incorporate longitudinal data to then predict overall survival and survival compromised by these major types of complications. And we took into account several clinical variables. So we looked at performance of different DeepML models. One of them was the transformer model, which ended up being best performing with an overall survival AUC of 0.77. And this was in comparison to logistic regression at 0.71. And for 5-year survival, it was 0.711 as opposed to 0.648. But then when we looked at the different types of compromised survival, cardiac, cancer, and infection, this ranged from 0.804 to 0.83. So better performing for specific types of survival compromise. And then we did a cross-validation with our data at Toronto at the University Health Network, and we had quite good external validation of these findings. We then were able to determine by SHAP analysis what were, say, the key predictors of these survival outcomes, and then we also have now, say, a front end that was developed for deployment of this specific model that we started to deploy a few months ago. So, but we ran into some issues, admittedly, with the transformer model deployment via Epic. So this was via our electronic medical record system. And we are now fixing those issues, and I can get into that during our panel discussion. But we are working to fix those issues and sort of focus a bit more on specific events as opposed to actual survival. And we can talk about that a bit further. But we actually, like, the interesting thing, we also did some human healthcare factors analysis work, including surveys and interviews of physicians in our program to see how best to present this dashboard. And we also have, say, the ranked features for each individual patient that predict those outcomes. Finally, I'll conclude with optimizing post-transplant graft survival. So you have the liver transplant that has occurred, and now you want to optimize the life of that liver itself. And you know, I'll start off by you know, a shout out to Anna Goldenberg. This was actually a work that was driven by an undergraduate student who worked with her and myself to develop and validate an ensemble machine learning algorithm for all-cause advanced hepatic fibrosis. So this was more in the chronic liver disease realm. So I won't get into the details of this, but this actually inspired my team to then look into the liver transplant context. And so in liver transplant recipients, there is acceleration in scarring for any given degree of injury. So if you have any inflammation in that new liver, it progresses much more rapidly than, say, in the non-transplant context. So if you look at the native liver, it takes 3 decades, 4 decades to actually develop cirrhosis for the most part. But in liver transplant recipients, that same process takes 5 to 10 years at a minimum, so 5 years. So what we realize is that there's a much shorter time window for us to actually make changes in their care to prevent progression to cirrhosis and graft failure. So then they end up losing that liver, and that is an unfortunate loss of such an important resource in their second life, right? So you want to optimize that. We want to optimize that. And so, you know, this was work driven by, at that time, a postdoctoral fellow. Now she's an assistant professor at York University in biostatistics, Divya Sharma. So she drove this work, and this was in co-supervision with Wei Zhu at UHN, and again, clinical research fellow Amir Agier. So both of them drove this project forward to develop a new method to suit data set features. And I would say, you know, in this case, we looked into 29 longitudinal blood test results as well as clinical characteristics. And the idea here was to develop a modified version of the long short-term memory network through a weight loss function to minimize bias, because the cases were actually lesser in number than the controls. So she kind of increased the training on the cases in order to optimize predictions. And so the idea here was to detect any patients who had significant liver fibrosis in their graft so that we could, say, predict and optimize their care so as to prevent further progression of their fibrosis. And so this algorithm was best performing as compared to other deep ML algorithms. It's the weighted LSTM, as she called it, and so it had an AUC of 0.798, and top ranked features are listed here, which actually concord with clinical intuition and clinical domain knowledge that we know from the retrospective studies as well. So, having such SHAP analysis, certainly as a clinician, having access to these ranked features actually makes me, trust the output predictions of a model particularly. So now I'll conclude with another solution that we've developed, again by Divya. So we often face this situation both on the liver transplant ward as well as the outpatient unit, where patients will have elevated liver tests. And again, you look at patterns in those data, and I found myself looking at patterns in those data and thinking, well, rejection seems to have this pattern, whereas bile duct obstruction or bile duct issues have this pattern, viral illness has this pattern. So it would be very interesting to develop a tool that could give us a better sense as to what actually is going on even prior to a liver biopsy being performed and the results of the liver biopsy. So there's often a time delay in that whole process of finally getting the liver biopsy result. So a physician will often have a hunch based on liver test results and then may start modifying treatment even before the liver biopsy has been reported, right? So, and there can be a few day time delay. And in transplant patients particularly, you want to start making changes that are going to improve their outcomes from that particular illness admission. So Divya, again, developed this particular tool called Graft IQ, which incorporates all the different, say, blood test results as well as clinical characteristics. So the age, the sex, the indication for transplant, immunosuppressive regimen. So all these different characteristics, both clinical and laboratory factors. And so she developed an artificial neural network model to predict multi-class. So it was a multi-class ANN to determine into which category a patient fell, and it had an AUC of 0.866. And this was the SHAP analysis, which actually makes sense, again, from a clinical perspective, for acute cellular rejection, biliary complications, biliary complications, very clearly the alkaline phosphatase and total bilirubin are going to be elevated in those patients. So all of this, makes sense from a clinical perspective. Then we did an expert versus machine implementation analysis. So we got 12 hepatologists into a room and presented them with 30 cases. I was in there as well. And in fact, very interestingly, very humbling experience, the ML model was actually better performing in terms of predicting what the graft pathology was. And then what Divya did was she then incorporated that knowledge. So she applied Bayesian inference principles to fuse that prior knowledge provided by clinicians with the likelihood computed by the ANN. And so she weighted the combination of probabilities by the ML model and the clinician to then allow for better prediction. And you can see here to the right, the AUC integrating clinical insight and some clinical decision rules that I also gave her basically allowed this algorithm, so it taught this algorithm to do much better in its prediction. So in a statistically significant way. So I think overall, what I hope I've, convinced you of is, I think first of all, it's very important to work very closely with clinicians. I think you heard that through the talks by Anna yesterday and Laura today. So I think it's very critical for computer science trainees to acquire that in-depth knowledge so that then you can develop solutions that are meaningful and that are really based on that domain knowledge. So it does require you know, an understanding of each other's language. So that's not easy, actually. Like many clinicians may superficially use or try to develop AI models with collaboration, but they may not have a full understanding as to what you are capable of doing and vice versa. And I think it's very, very important actually for both sides to learn much more in depth what from your side, you know, what are important clinical problems and what are the clinical nuances? Because I think, you know, some of the methods or the tools that we developed were really based on, you know, they were new methods developed for that specific question. And I think that only happens when you have very close crosstalk. And so in the liver transplant world, as is the case in the clinical world in general, there's so much data that we're acquiring. There's so many hidden interrelationships and patterns and complex data. And I think, you know, ultimately we want to be able to develop these tools that can then be deployed and implemented so as to optimize the care of patients we take care of. So on a day-to-day basis. So I'd like to acknowledge my key collaborators and trainees, you know, both in my group and co-supervised, and you know, we have this Transplant AI initiative, which you know, is very active in both the development and deployment of AI tools, and I'd like to acknowledge our funding sources as well. Thank you.